Hello, everybody. This is Leppäniemi from Finland. Nice to join you with this virtual meeting. We see how it works. Anyway, so hope to see you soon in person in the near future. So meanwhile, we have to settle with this. So, topic today is trauma and laparoscopy, reality or fiction. Although I have nothing to disclose, I have a bias. I think big mistakes are made through small holes and complex trauma surgery is like a parachute. It works better when done open. But there's evidence to see. But first, a little bit of history. From the early times, non-operative management of abdominal trauma was a standard until 1890s, when they started to do laparotomies. Sims was the first to do it in 1881. And then the mandatory exploration was sort of the norm until 1960s, when Jerry Shafton first said, well, wait a minute, why should we operate on all? Because a lot of them don't have any injuries. And therefore, selective management has been used and studied in stab wounds first in the 70s, and then later in the gunshot wounds and blunt trauma as well. Now, there are a few critical observations. One of them is that we know that if you operate on all, there are a lot of people who don't need the operation, and there's some morbidity associated with unnecessary laparotomy. And of course, it's also expensive in a way. On the other hand, we have new techniques for diagnostics, imaging techniques, and also endoscopies, cavitary and natural orifice endoscopies, plus non-surgical intervention, percutaneous drainage, endoscopic, and geographic endovascular interventions. So to start with, what happens if you operate on everybody? And about 37% in this study from our place long time ago, and up to 50% in other studies show that there is no injuries. So that is a non-therapeutic laparotomy, no injuries or injuries that don't need any treatment. Although nobody really dies of unnecessary laparotomy, there's still morbidity involved, about 20%, mostly wound and pulmonary complications. And of course, they stay in the hospital much longer than needed if they would not be operated. We know, on the other hand, there are some patients who really need to be operated. This is again from our place. Consecutive stab wounds, if patient is in shock, bleeding, has peritonitis, vomits blood or passes blood in the stool, they need to be operated regardless. On the other hand, if you can demonstrate that there's no peritoneal penetration, then those patients need not to be operated. Evisceration of omentum of bowel is more controversial. Most people would operate on those. And then again, if you see fluid or air in the imaging studies, that's again something which is not very reliable. How can you evaluate if there's a penetration in the peritoneum? You can explore the wound under local anesthesia, but sometimes the patient is obese or is athletic. It's not so easy to find it. Sometimes it's better to see the intact anterior fascia rather than peritoneum too. If that is intact, then there should be no penetration. Obviously, laparoscopy could be used for this to evaluate. And there was a study in 2007 when they did a vague laparoscopy for penetrating abdominal trauma in the emergency department. And it could actually show whether there was a peritoneal penetration or not. However, somehow this hasn't really taken or being used in practice, and we don't do it, and I doubt if any institutions do it now. If you look at non-operative management, the Cochrane Library, you see two studies from some guy from Finland evaluating this. One of them was a randomized study comparing patients who don't need immediate surgery, who are stable, no peritonitis, so forth. They were randomized to laparotomy or observation. And you could see that in a lot of cases, the observation was safe. There was no early mortality. There was some morbidity, but obviously those who were operated stayed in the hospital much longer than those who were treated non-operatively. Plus, you save money if you don't operate on everybody. Interesting, there were 4 patients out of 24 in the observation group who have delayed recognition of injuries. So there's a price to pay for that. But in most cases, it doesn't really lead to severe problems. Laparoscopy in trauma can be used in 3 ways. It could be a screening test to see if there's any finding or exclude any positive finding, including hemoperitoneal, gastrointestinal spillage, and so forth. It can be used as a diagnostic test where you try to identify all injuries that require treatment, not just one indication to do a laparotomy. And then, of course, you can do some therapeutic laparoscopy where you can actually repair injuries laparoscopically. Salomone Di Saverio and his colleagues published last year this paper on the 6 whys in trauma laparoscopy. The potential benefits are obviously lower inflammation and trauma to the patient, less negative laparotomies, less pain, probably at least in the long run, less adhesions, incisional hernias, and obviously surgical site infections probably as well. And they recover faster and you save money. However, there are the downside of it, which is negative rate, which is still fairly high. You have some specific complications included or associated with the laparoscopy. And then pneumoperitoneum in some patients could be a potential risk for hemodynamic compromise. And at least in some cases, you can also spend a lot of time doing laparoscopy and try to see whether you can find anything reliably. Now, we think it's a new thing, but actually the first laparoscopy with the cystoscope was done in 1925. And then there are some trauma laparoscopies in the 70s, and Gatzanika in 76 actually was the first sort of study which is always referenced to. We did a prospective study published in 2003, actually 2 studies in one, because we stratified the patient based on the risk of peritoneal violation. We know that from the studies that you have mental evisceration, positive wound exploration, air or fluid in the abdomen, you have about 60% chance of organ injury recurring repair. So that's the high risk group. Then on the patients where you can not definitely define that there's peritoneal violation. So you think maybe or maybe not. We know that these patients have less than 10% chance of having an injury requiring repair. So that's a low risk group. So we incorporate laparoscopy in both these studies. And you can see that, of course, some need to be operated right away. High risk group randomized laparotomy or laparoscopy. Then low risk group, you randomize laparoscopy or non-operative management. So the high risk group, you can see that this is laparotomy and this is laparoscopy, diagnostic laparoscopy. That conversion was done in laparoscopy group about half of the patients. Non-therapeutic laparotomies were only in 1 compared to 65% in the laparotomy group. There was no mortality, morbidity was minimal. Surprisingly, though, there was little change or little difference in the hospital length of stay, just less than a day more in the laparotomy group. Also, there was no difference in cost. If you look at what other peoples have found, you see that you can prevent laparotomies in doing laparoscopy in these patients in about 50 to up to 87%. So that's the clear benefit you can have. In the low risk group, laparoscopy versus non-operative management, you can see that therapeutic operations were rare in about 3 or 11%. they had injuries, more injuries recorded with the laparoscopy, but most of them were injuries that didn't need any treatment. So they were minor injuries. No mortality again, some morbidity associated with laparoscopy. Not again much difference in hospital length of stay, but the cost was much bigger with laparoscopy, about 3 times. And also the patient needed more sick leave when they underwent laparoscopy. So we concluded from that study that as a routine diagnostic procedure, diagnostic laparoscopy cannot be recommended in anterolateral abdominal or lower thoracic stab wounds. There might be a subgroup of patients who could benefit from that, and especially patients with isolated diaphragmatic perforation. Now we know that penetrating thoracoabdominal trauma is associated with the diaphragmatic injury in about 1 patient in 5. And most of them have other injuries too. We don't really know the natural history of diaphragmatic perforation, whether it heals or not. And we have seen many delayed complications when there's herniation and organ necrosis through the hole. And we compared from these 2 previous randomized studies, those with observed and those with explored patients. And we actually found that 9% of those who were explored had a diaphragmatic injury. So we could assume that in the observation group there are some as well. So overall, the incidence was 9%, and occult, meaning they had no other injuries, 3 out of 43. And 2 of them have delayed presentation. One had a herniation of the stomach in the chest, and the other one had most of the bowel herniated in the chest that required many operations. Both of them survived, but had a prolonged morbidity and length of stay. So we could conclude that on the left side, especially, the incidence or risk of an occult diaphragmatic injury is 17%. So what can we say in abdominal stab wounds? Laparoscopy is accurate to detect or exclude peritoneal penetration. It can decrease unnecessary operations. It's good in detecting diaphragmatic injuries. Probably with experience, the skills to find or exclude injuries would become better, but we need more research, obviously. Now, this is an interesting study, a report from 2 years ago saying that laparoscopy as a diagnostic tool was good for excluding peritoneal penetration. And they sort of pretty much confirmed, which we knew by that time already. Going to gunshot wounds, we know from George Wellmhouse's study already 20 years ago that some patients with abdominal gunshot wounds don't need to be operated in an analogous way, although the risk of injury is higher than after stab wounds. But we know also the CT scan is actually a very good tool. Here's a study from Sosa and others on laparoscopy in abdominal gunshot wounds, a prospective study where they could actually treat or have about 18% of patients undergoing diagnostic laparoscopy. So the rest were not suitable for that. Out of those 121, 1/3 were positive. You can see the injuries listed there, and 7 were non-therapeutic. And those who had negative laparoscopy didn't miss any injuries. So the sensitivity and specificity were reasonable with laparoscopy. As far as blunt trauma, Alfred Cuschieri already long time ago said that it's a mini laparoscopy with peritoneal lavage could be something we could think in blunt trauma. Obviously, time has passed from that. If you put together studies in blunt abdominal trauma, you could see that actually in 63% total on these studies, you could prevent a laparotomy with laparoscopy. And we did a collective review showing laparoscopy having fairly good sensitivity and specificity in blunt trauma. The others have done other studies confirming those findings. But of course, there's also other alternatives for diagnostics, which is of course CT scan. I come to that a little later. Now we know that through laparoscopy, you can repair a lot of things because a lot of people do laparoscopic operations. You can suture bowel, you can suture diaphragm, you can resect bowel, you can do a lot of things. In this study, they did a lot of therapeutic procedures, didn't have any missed injuries or conversions, but obviously this is a selected material. When they look at the time trend, it's kind of interesting to say that from 1990 to 2016, there's actually significant decrease in the use of laparoscopy in trauma patients. So obviously there was an initial enthusiasm, and then after that, other things have evolved, and laparoscopy has gotten less popular. Also, we don't have any significant evidence to support the use of laparoscopy. So as said, CT is still the king in stable patients. And here you compare CT and selective laparoscopy. And actually, where it might be a place for laparoscopy in trauma is if you have CT, which is indeterminate, with thickening bowel wall or free fluid without solid organ injury, something like that, you're not sure, you can do a laparoscopy and then prevent a non-therapeutic laparotomy or delay diagnosis in suspected bowel injury. So there might be a space for laparoscopy after indeterminate CT. So all this to conclude in plain English, in penetrating abdominal trauma, laparoscopy reduces non-therapeutic laparotomies. We know that. It has some benefit in recovery times and cost savings, and it's pretty accurate in excluding or treating diaphragmatic injuries, especially after thoracoabdominal wounds, especially on the left side. It is probably more useful in stab wounds and gunshot wounds. In blunt trauma, it's pretty good in intraperitoneal injuries, not so good with retroperitoneal, obviously, where CT is much better. And I would go that CT is the first line treatment in blunt trauma, diagnostic tool in blunt trauma. But there might be place for selective use if the CT is indeterminate. So to answer the question, laparoscopy and trauma, reality or fiction? Not reality of fiction or fiction. So it is reality in a way that it is used in centers who have skillful, enthusiastic laparoscopists, although the evidence, as I've shown, is not so strong. It has some benefits in selected cases listed there, but it's not suitable for patients with unstable hemodynamics, peritonitis, adhesions, and overall, CT probably gives you more information. So it is a fiction in a way if you think that it should be used routinely by all trauma. That is fiction, that is not true. So we have to be selective and careful when we use laparoscopy for the right and not the wrong indication, just because it's fun to do. And that's the catch of last summer's pike, 9.5 kilos. Wish you all have a good meeting. I hope to see you in person very soon.